Welcome to Moving Conversations, a podcast for movement professionals by movement professionals. If you coach, train, or teach movement, Pilates, or fitness, then this podcast is for you. With more than 60 years of experience in fitness and Pilates, your hosts Brian Ritchie and Nora St. John explore the science of human movement, diving deep into the facts, myths, and common misconceptions, hoping to spark thought and conversation about how we view fitness and movement. Now, let's jump into Moving Conversations. And welcome back to Moving Conversations. I'm Brian Ritchie. Joining me as always is Nora St. John. How you doing this morning, Nora?
Very well, thank you. Just getting ready for Thanksgiving. It's that day before when you're contemplating, how am I going to make all the things I have to make and how am I going to get where I need to go tomorrow?
Well, are you guys, now I know sometimes you guys do Friendsgiving, sometimes you go, are you staying home? Are you heading out? Or?
We're heading out to the Bay Area just to see family. So it's going to be a small one, just brother and sister and their associated people. So it'll be a small one.
Nice.
What about you?
We head out tomorrow morning. I want to say bright and early. I don't know if my family's going to agree with that. We're going to West Virginia to my wife's family, and we'll celebrate, stay the night, come back on Friday so we can have a chill weekend, hopefully. Let's hope.
Nice.
Yeah.
Nice.
Yeah, I'm super excited about today's topic. As everybody knows, the spine is sort of one of my specialties. So today we're going to cover stenosis. We've covered some, non-specific generalized low back pain issues in the past. We've done herniations, and you and I were talking, and we're like, we haven't jumped into stenosis. So I thought that would be a good one to hit today and, dive in a little bit. I've got a ton of experience with it, and which is odd that you haven't had as much experience as I have. So I find that, just interesting, and, who knows why, but, just is what it is.
Excellent.
Yeah.
So we're talking about stenosis, and this is really common. They say like 200,000 cases a year in the U.S. Just look at my quick statistics on the web. So really, really common. And one of the things that I like to say about stenosis is very often it is a wear and tear over time developing process. And because of that, it can sometimes be challenging to really solve it.
Yeah.
Right? It's not like a disc injury, which really will heal and repair itself. Stenosis generally can be managed, but it isn't necessarily going to heal.
That's kind of what I have discovered in general is it's wear and tear. It's something that is much more, arthritic based, or it's going to happen to the ligamentum flavum. It's going to happen to the facet joints. It's going to happen to the intervertebral foramen. Something is going to get occluded, or the canal itself is going to get occluded. And that's going to cause, the disruption of the nervous system. And it's just going to pinch off, and, you kind of got what you got after that.
Right. So thinking about stenosis. So stenosis just means narrowing.
Yep.
Okay, so just as a definition, and what is typically narrowing when we talk about the spine is there's two different versions. You can either have narrowing of the canals that the nerves lead out of from the spine, or you can have a narrowing of the central canal that the spinal cord goes through. Central stenosis or more lateral peripheral stenosis, usually what I hear those called.
Mm-hmm. And the easiest way that I've known to sort of figure out which it is, if a client comes into me and they say, let's face it, our clients, when it comes to their bodies, let's just say they're not the most intelligent on what's going on. And sometimes they come in and they say, yes, I have stenosis. Usually they say, I have a stenone, and it's, and they don't even know exactly what they have. So I have to sort of throw it out there like I'm fishing, you got to Hansel and Gretel it, throw some things out there until they go, that's the one. And if they say stenosis, then I'm like, okay, did they mention central or lateral?
What kind or where even?
Right. And their eyes just sort of, bug out at me. So it's usually like, okay, let me ask you this. Does it affect one leg or the other, or does it affect both legs? And is it affected most when you're standing or, not? Central stenosis in general is going to be most angry in prolonged standing positions. Anytime you're in extension, it's going to be a little bit more angry. So people who stand or walk, this is the person that walks half a block and they have to sit down to take pressure off that nerve root. And they'll usually feel it down both legs, or they'll have weakness down both legs. Whereas lateral stenosis is usually just arthritis within the intervertebral foramen, and it affects one side. not always the other side. So that's the one way that you can sort of tell when they come to you is, which one do they have?
Nice. And that's an easy, it's not necessarily an easy fix, but it's a nice way just to know, because there's a little bit different ways that you work with those
Yes.
two, right? I mean, fundamentally, the pain comes in when the narrowing occludes the nerve or puts pressure on the nerve. So you have all the nerve symptoms that you might have with a disc problem or other kinds of things: weakness, numbness, tingling, pain, right? Shooting pains, all those things. And they may not be in the back. They're often in the leg, in the foot, in the thigh, in the butt. So oftentimes you'll have referred pain or distant pain, and the back may or may not hurt itself. So sometimes those are some other clues about what might be happening.
Yeah, this I find in general, they will say, especially with lateral stenosis, if it's just on one leg, they do have either the numbness, tingling, radiating pain, or they'll say they have this weird achiness in their glute. And and it'll be mainly in the glute, and it'll work its way down the leg a little bit, but they'll often will also say it just feels heavy, especially if they have central stenosis. They complain about heaviness in their legs. And that can definitely be part of it. We also sometimes will see some muscle weakness, involved in that as well. And how it was explained to me, and if it was explained to you differently, please, jump in. But the nerve itself sort of has a sensory area and a motor area. And the sensory area is more on the peripheral side of the nerve, whereas the motor's on the central. So when it's first getting occluded, getting impinged, you're going to have that numbness, tingling, radiating pain down the leg. You're going to have sort of that part of it. But when it's been impinged for a longer period of time or more severely, it's going to start affecting your motor function. This is where we'll see drop toe. This is where we're going to, or drop foot. And and sometimes when it's gone that far, you can cause some pretty serious and prolonged issues, and some people don't get all of their motor function back.
Right. Yeah, once a nerve is impinged for a period of time, it will just not return, whether it's sensory or motor. Sometimes you get some numb patches, or you'll get some motor loss. And motor loss is something, if you ever have a client who has any kind of a back problem, starts really having that kind of weakness, whether it's in the periphery, so like foot drop is a classic, meaning they can't dorsiflex their ankle, or they just feel very weak in one leg, or loss of bowel and bladder control is another thing. Like if they really feel like they're starting to get funky there, that is always a time to refer back to a doctor, because that means you've got a progression that needs to be dealt with, possibly surgically, but certainly by somebody other than you.
And immediately. They need to really get in. When it gets into bladder, bowel function, again, that is way beyond our scope of practice. That is way beyond. I don't want to deal with that. You just say, okay, you need to go see your doctor immediately, because keep something in mind. As exercise professionals, we can help a lot of issues. We can help manage a lot of conditions. However, there is a point to every condition where it goes beyond what we can do.
Absolutely.
And that's when we need to be, smart enough, and also take our ego out of it, that we can help people and just say, you know what, we may have done all we can. I think it's time for you to get a little bit more treatment, whether it be physical therapy, whether it be, surgery, just some other intervention that's beyond what we can do.
Right, exactly. And that's just important to know anytime you're dealing with clients with injuries, is what are your limits? What do you know? What do you not know? And you always, and then we've said it before, but have a great referral network. If you have a wonderful group of people that you work with, doctors, physiotherapists, other, massage therapists, if you've got a great group to refer people to, you become a valuable resource, not just for your clients, but for their friends and anybody else that they may refer to you. And so really important.
You become this network where, I refer people to my massage person, to my chiropractor, to my orthopedist, to my physical therapist, and they all refer to me, and it becomes this little, network within a network that we're always sharing people. We're always sending people back and forth. And I'll be honest, I've been on the receiving end a lot more than just the giving end, because good trainers, good Pilates instructors, in some areas are few and far between, to have someone that the doctors or physical therapists can actually trust their clients to. So if you're good at what you do and you create this network, it's not that you're admitting I can't do it. It's more like, hey, I know other people that can help you out. Here they are. And now they're going to send people back to me as well. So it really, I mean, it's invaluable in my opinion.
Well, so many things for the low back, particularly other areas as well, but particularly for the low back, you cannot solve in a 4-week PT prescription.
No, not at all.
In a 4-session PT, because it's postural, it's habit, it's strength, it's mobility. None of those things are going to change all that much in a short period of sessions.
Yep.
So, a lot of good physical therapists and good MDs are like, well, your PT may have run out, but if you've got the finances, if you've got the resources, go really work on this project from a movement perspective, because that's going to make the long-term change for you.
And not only that, I find with physical therapy, at least in this area and with the insurance industry, they may be limited as to whatever the prescription says. So if all they're dealing with is the low back, well, that's fine. But if that's all they focus on, they may not focus on lower leg strength. They may not focus on core integration with the rest of the body. So that's what we can do. We can take them to that next level and really work the whole body and get their spine working on a much more dynamic or just, movement oriented, place to be. And that's kind of where I always say, look, they are dealing with one area, we can deal with everything, and the integration of the entire kinetic chain.
And in terms of the spine, and particularly coming back to stenosis, a lot of times what we can do over time, right, this doesn't happen in the first session or the second session, is create that length of the spine, that sense of that decompression of the spine. So much of the core work that we do is exactly designed to decompress the spine, which can lead to decreased pressure on the nerves and then decreased symptoms. And with stenosis, that's a lot of what we're looking at, is how do we decompress the spine? How do we create more space for those nerves to go through those canals so that they're not getting pinched, they're not getting impinged, they're not causing symptoms?
I want to go back to, just in case, you have a client and you're not sure whether or not to refer them out. When it comes to the nervous system, I had a client who, this person was very close to me. Their family helped take care of me when I first came into Washington, D.C., so I was, always trying to take care of them. I was working with this guy, and he started complaining about his lower leg, and he had diabetes. So he went into his doctor. Immediately, the doctor starts treating him for peripheral neuropathy, because thinking that must be it. It has to be a circulatory issue. And he went from doctor to doctor to doctor over 6 months, and it just kept getting worse. And what he said was, I'm having a hard time going up and down stairs. And so, but he says, I feel it fine. Because he didn't have any problem with numbness, tingling, radiating pain. Wasn't until he went to a rheumatologist, his wife's rheumatologist actually, who said, turn your head to the left, turn your head to the right, turn your body to the left, to the right. Oh, you've got arthritis of the spine. He wasn't blinded by the fact that he had diabetes. He was just looking at the body and how it moved. And they, of course, did an MRI. They did the x-rays, and they found exactly that's what it was. So for some people, they may never have that numbness, tingling, radiating pain. They may go straight into the motor function aspect and not be able to go up and down stairs. And I've had a number of clients with low back problems when they go in to see the doctor. That's a big question that they ask is, can you walk up and down stairs comfortably? Does your leg ever feel like it's giving out on you? So it's something that I'll ask when I see a client and they say they have low back pain and they have stenosis or any type of condition that might lead to impingement. I'll just say, do you feel weakness going up and down stairs? Do you ever feel like your leg's giving out? Because truthfully, if they're at that point, I really want to make sure that they've seen the physician first. Because there may be something going a little bit beyond what we're going to want to do. And just having them checked out ahead of time and getting that medical professional to say, nope, you can go for it. I want you to work, this person, then it's fine. So I just sort of wanted to get back to that nervous system is very strange. Sometimes you'll have just the numbness, tingling, radiating pain or referred pain. Sometimes you don't. But if it starts to affect any type of motor, that's when you really want to get them in.
The other thing too, to build on that, is the low back is a source of pain for many different conditions that have nothing to do with the musculoskeletal system. So low back pain can show up in cancer. It can show up in other kinds of metabolic issues. It can show up in some circulatory issues. So if this is challenging for those of you who are new in this profession, but if something really isn't resolving the way it usually does in any part of the body, like if they've got an ankle sprain and usually it takes X amount of time to get better, and it's really not getting better. And in fact, it's getting worse, and that's all of those are times to send them off to somebody else.
Mm-hmm.
And, with low back pain, I'm always just looking out for, are there any other symptoms? Have they lost a lot of weight recently? Have they gained a lot of weight recently? Are there any other things, like they're feeling weak? Are they feeling tired? Are they like just keeping half of your eye out for other things? I've had two different, one was a Pilates teacher friend of mine who was dealing with low back pain, and it turned out it was a tumor. And really it was a tumor on the spine. It had nothing to do with the musculoskeletal system. I couldn't do anything about it. And another client who, it turned out it was pancreatic cancer, and their symptom was showing up as low back pain. So not to freak you out, but just to remind you that low back pain is a way that the body talks to itself, the way the body says something's wrong, and it can often have nothing to do with what we're talking about. So again, another reason just to keep your eyes open, keep your mind open. If it doesn't smell like a musculoskeletal thing, send them back to the doctor and have them dig a little deeper.
Yeah, I've told many people this. If it looks like a duck, quacks like a duck, smells like a duck, but it ain't a duck, something's going on here. Get them in. Get them in. So, yeah.
And from your story, because their story brought this up for me, because the doctor just saw client diabetes foot.
Yep.
And so he went straight for peripheral neuropathy, which honestly is in my experience, is rarely motor. Yep. It's much more sensation and numbness and that kind of thing. So I'm kind of like, but he had that in his mind, right? Yep. And that's very common, that we bin people a little too early into some category or other, and doctors often have a limited time to do that, so they'll bin them quickly. And that kept him 6 months from something that somebody with a different lens would have figured out much more quickly.
Exactly.
So just something to be aware of.
And I will say, he was furious. He was so upset because he wasted 6 months of pain.
Yeah.
And once we had the right diagnosis, then it was like, oh, okay, then I knew what to do, and immediately put him through, and he was managing it within a week. He said, oh yeah, things are so much better now. But if he hadn't gone to another doctor, if he hadn't gone that one extra step, they would have continued to treat him for the peripheral neuropathy and not, because they thought maybe it was gout. They were looking at all sorts of other things besides musculoskeletal.
Yeah.
So again, that's something else that I remind people about is, go ahead and get a second opinion. It's only going to help. It's never going to hurt. Get 2 or 3. It's time, but it's nothing more than time.
Right. I mean, it may be money too, but
true.
it's again, and if you're not getting the results you want from us, from anybody, right, then try something else, because not every modality is right for every person at that moment.
Yep.
And if you really are not getting where you want to go, keep digging, because that's an important thing.
Yep. So when we're talking about stenosis, there's 2 areas that it normally will occur in, this, either the cervical or the lumbar. I've seen a lot in both. And they both present very similarly, that normally they do present first with the nervous system, where you're going to get that numbness, that tingling, either down the leg, depending on what area it is, because we look at the dermatomes, and you might have, more on the lateral thigh, you might have it down the calf, you may have it in the foot or wherever, based on where the impingement is. Or you could have it more generally down both legs. In the cervical, it's usually down the arm, down into the hand. And that's usually a good indication that, okay, something's being impinged.
Yes.
Yeah.
The nerves are involved somewhere. Typically we think about the spine first. It could be from, muscle tension further down the chain, but typically it's somewhere in the spinal system. That's usually what we're thinking.
Yeah. So again, when a client does come in and say they have stenosis and they start presenting with additional issues, we want to make sure, okay, are they doing their exercises? Are they in the right position? And normally you and I have done class after class after class on pelvic bias and trying to get their spine in the right position in order to decompress those nerves. And much like spondylolisthesis, when we're talking about stenosis, we want them to be in more of a posterior tilt, so we're opening up that intervertebral foramen so that we're opening up the spinal canal and, hopefully reducing some of that impingement.
Yep. Right. So that's the idea, right? It's like just open up those spaces, a little bit more flexion, a little bit less extension. And sometimes I've had many clients, those that I've worked with, where we really just stayed neutral to flexed the whole time. Like we really would not go into extension at all. Now, the other thing too, though, is so that's postural. So Brian, you've talked to me some about ways that you coach your clients to decrease their symptoms. What kind of cues do you give them in terms of ways that they can work with it? Like a client, for example, who walks and has a lot of pain after a short time of walking. What do you suggest to them?
Yeah, with a client like that, a lot of times what I'll do is, first of all, if I know that it's central, if walking half a block, they begin getting that heaviness in their legs or whatnot, take a seat. Have a seat first, okay? Because that's going to take the pressure off of that. Sometimes you can't do that. So I'll just say, I want you, as you're standing, bend your knees a little bit more. Tuck your tailbone under. Don't go into, and if they're walking, shorten your stride just a little bit. Because something that people forget about is that a lot of times when we have back issues, we get that dormant butt syndrome, that gluteal amnesia. Our butt's not firing as much as we want it to. So every step we take, we're using our low back muscles to pull us into hip extension, which pulls us into a little bit of spinal extension. And with that spinal extension is just going to give them increased symptoms. They become more symptomatic. So just by tucking the tailbone under just a little bit to open up that space, getting their abdominals engaged as they're walking, that can often help. And I'll tell them, if they're on the treadmill or something, I say, slow down. Don't go as fast. Something else is I'll have them go at a little bit more of an incline because now they have to lean forward a little bit. So with that leaning forward, they're opening up that space a little bit. And I'll say, slow down and put it at, 5% incline. So as they're leaning forward, they're like, oh, that's not as bad.
Good.
But when you're walking out and, outside, it changes things, which is good. I want people to walk outside, but it does change things. I find that a lot of people want to lock their knees when they walk or when they're just standing. And as soon as they do that, they go into more spinal extension. They sort of dump into their low back.
Yep.
I literally this past week had a new client, who read an article that I wrote after I wrote my book. And he found me through the article, found the book, and he'd been suffering from stenosis, spondylolisthesis, both need to be posteriorly tilted. He'd been suffering that since he was 14.
Wow.
He had a trauma, sporting accident, was put in a back brace. He's an older gentleman, so that was when they used a lot more back braces. It pitched him forward. It got him out of pain. But then he decided upon retirement or semi-retirement, I need to get in better shape. I'm going to start walking more. And immediately his back started bugging him. And it started getting worse and worse and worse. And he went to doctors, PTs, and everybody wanted him in neutral spine or even some extension. And he read the article, and it was about being in the posterior tilt. And he said as soon as he started that, it went away. And I saw him this week virtually. He's in Florida. And I started, looking at how he stood and things like that. And just by correcting his posture a little bit, I said, look, you're not going to be able to stand up perfectly straight. You're not going to have military posture. It's just not in the cards for you. So tuck your tailbone under, bend your knees a little bit more. Think about lengthening the spine upward, so you can still pull your shoulder blades back, but then he'd pull them back and he'd go into more of a sway back where he's leaning back. I said, no, we don't want that. You still want to be over the toes, and it was just trying to find that position where he wasn't arching his back, that he was opening up his lumbar spine. But as soon as he did that, he said, wow, yeah, I have no pain standing right now.
So this is something I have seen a lot with stenosis, both in the cervical and in the lumbar, is the feedback can be pretty immediate.
Yes.
So in other words, like it hurts and I change my position and it stops hurting or it stops feeling heavy or whatever the sensation is, which is nice because that's immediate feedback.
Yeah.
And then you can really just work with, okay, that feels better. That's where we're going to stick and that's what we're going to train you.
Yep.
Right, we're going to train you in a little bit of a posterior tilt, a little bit of lumbar flexion. That's where we're going to live.
Yep. And that's something to think about for any client that comes to you who has low back pain. Stenosis, as any degenerative issue with the spine, you know, they're going to have low back pain. They may or may not have seen the doctor, but they still want to exercise. So like you just said, what position feels best?
Yep.
So I ask them, does it feel good to sit or to stand? If it's standing, it's usually a disc issue. That if they like to stand, they like to be an extension. If they like sitting, if they automatically flatten their back when they lie down, hey, they need to be more in a posterior tilt. I don't need a diagnosis beyond that necessarily. I need to train them there to start.
Yeah.
You know, find the position that doesn't hurt, whether it be flat back, neutral, or a little bit of an arch.
Now, I want to bring up too, just because I'm working a lot on the neck lately, but this is true in the cervical spine as well.
Absolutely.
That we talk all the time about a neutral lumbo-pelvic position, and any of you who've trained either Brian or I have heard those terms pop out of our mouths. But the same thing is true in the cervical spine. And again, if there's symptoms in the upper body, now remember the cervical spine is at the top of the spine. So if there's impingement, especially central impingement up at the top, you can have symptoms anywhere down the chain.
Yep.
You can actually have leg symptoms from a cervical spine issue. So just to be aware of that. But basically, it's the same thing with the neck. Do I need to gently nod my head forward and flex the spine? Do I need to not really look up at the ceiling? Do I, can I turn right? Can I turn left? What again, position of my neck is going to also provide that same kind of symptom relief for generally the upper body or the symptoms of more of a cervical stenosis. I just wanted to bring that up because we talk a lot about the lumbar, but the cervical also you need to think about neck position or spinal position.
Absolutely. And I believe in bolsters, pillows, whatever it takes to get them in a position where they can relax their neck. Because chances are if their neck is inflamed, then they're having any, radiating pain down the arm or numbness, tingling, any of that sort of thing, and they're lying down, a lot of people who have some sort of forward head carriage will immediately tip their head back and will be almost like they're looking up. By just putting their head into neutral, by just putting a little bit of a block. And again, if they have any stenosis there, you may need a bigger one. You may need, a decent sized pillow. And I find that all of these cervical pillows, what do they all want to do? Put it right under their neck and it makes them arch their neck.
Exactly. They mostly want to put you into extension.
Right. Exactly.
Right. At least the low. Yeah. Yeah.
And that may be exactly what that client doesn't need.
Right.
So I always say put it on the crown of the head first. That way you can drop your chin a little bit. It'll elongate the neck. So we're going to decompress it a little bit. And again, sometimes I'll start a little higher than neutral just to see if it can take away some of that pressure.
Yeah.
I remember I had a client who came into me, and this is something about, that numbness tingling down the arms. When he came in, he said he was having an issue with his golf game. And he said, I can't putt anymore because I can't feel my putter in my hands. I said, that's interesting. He said, I could feel it, but I don't have the same feel. And I've been having a little bit of numbness in my fingertips, just a little bit. I said, okay. Went to the doctor. Doctor said, you have carpal tunnel syndrome, and scheduled him for surgery.
Yeah.
And I said, okay. And I asked him some very specific questions that are sort of classic carpal tunnels, questions. And he didn't have those. And I said, would you please do me a favor and get a second opinion? And, I said, look, I'm not a doctor, but I've seen this before. And this guy was a former football player in college. He's a big bull of a guy with a huge bull neck. And I said, it could be coming from somewhere else. I'm not saying it is, but it could be because I'm not diagnosing. I said, would you please do me a favor before you get cut open?
Yeah.
Would you mind? And he was, all right. And went in.
Was it bilateral, Brian? So was it bilateral?
It was mostly in his right, but it was in the left as well. Mostly right.
Okay. Okay. Carry on.
Yeah. And that's the fact that it was on both sides a little bit made me think, why would it come on at the same time for carpal tunnel on both sides?
Right. Exactly.
But again, I'm not a physician. So I just said, okay, just please. He went in to see, and I said, and do me a favor, see an orthopedist, not someone for the hands. See an orthopedic spine person. He goes, why? I said, it might be the neck. Who knows? Your neck is always tight, maybe. I don't want to diagnose. And sure enough, they said, oh my gosh, you've got stenosis. You've got a multi-level stenosis. It's just pinching off that nerve. No wonder. And, he went to PT, got some traction, and suddenly he could feel his hands again. So, getting him in the right position was going to be incredibly important because he was forward head carriage, big bull of a neck, and he had that numbness tingling down. One arm was more than the other, but it was a little bilateral. And my thought is always this: stuff rolls downhill. So if you have numbness in your fingers, it could be the wrist, it could be the elbow, it could be the shoulder, it could be the neck.
Yeah.
If you have numbness tingling in your elbow, it could be the shoulder, it could be the neck.
Yes.
It could be anywhere up the chain.
Yeah, but look at the whole chain.
Look at the whole chain.
I always suggest that. Yeah, I've had the same issue with carpal tunnel more than once.
Yeah.
It's like, just go back and make sure to just take a look at your neck generally. And honestly, almost every time it's been a cervical issue.
Exactly.
Not a peripheral issue.
Yep. So. Exactly. So that's just something, to take with you, when you're, thinking about this. Before we continue, I want to remind you guys, you're listening to Moving Conversations with Brian and Nora. If you want to hit us up on our socials, movingconvos@gmail.com. We've been getting some emails. People are enjoying what we're doing. If you have any questions or comments, don't hesitate. If you want us to cover a specific topic, we'd be more than happy to, put it in the pile with all the others. So hit us there. Moving Convos at Twitter as well as on Instagram. And yeah, so getting back to stenosis, let's stick with lumbar and hit cervical a little bit more afterward. Yeah. Because I find lumbar stenosis, it's pretty easy to get someone into that posterior tilt lying down. Mm-hmm. Because all they have to do is let gravity sort of take its toll and that back flattens. And if the client is, and something to think about, we see stenosis normally in people over the age of 65 in general, especially with central stenosis. Lateral stenosis, we'll often see degenerative changes starting in the 50s. I've got a little bit going on. I've got some facet joint syndrome just from, formerly abusing this back of mine. But we see that, and especially if you're talking central stenosis, we see it in the older people, especially older gentlemen, whether they have, a weight issue or not, they're going to be pulled into extension, and they're going to sort of collapse on that, on the spinal cord. So a lot of these people will have probably learned to do abdominals, things like curl, crunches, all that kind of stuff, with a flat back, because that was very common the way we used to teach it way, 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 way back in the day. So it's not going to be uncommon for them as soon as they lie down to flatten their back.
Right. And if I'm training, these are the clients I might do crunches with a flat back with.
Absolutely.
Right. Because the other thing is, how do I train them to maintain that position and to have strength and hopefully a little axial elongation, a little spinal decompression in that position?
Yep, absolutely. And this is the client we want to teach pelvic tilts to.
Yes.
We want to start them with something as simple as that, like, okay, here's a pelvic tilt. Now just hold that position.
Yep.
Now, in general, when I get people after physical therapy, a lot of times they've been taught to do a pelvic tilt using their legs. So they push down with their legs because the PT has taught them how to bridge, which is good, great exercise. But by doing that and teaching that to really engage their glutes, which they need to do, but they start trying to flatten their back only with their glutes. So I try and get them into more of their abdominals, to really, I tell them, zip up from your pubic bone to your belly button as you flatten your back. And then try and be lighter on your feet. I'll have them do marches. I'll have them do, things like that, so that one foot will be off the floor and they can really feel like, okay, my abs are really doing the work rather than my legs pushing down.
And that's a cueing thing for all of that, right? I find, again, sometimes it's just don't think about your butt. Don't squeeze your butt to posteriorly tilt your pelvis, which is, that's easy to do. And most people can get that. People have a lot more sensation there typically than in their abdominals until they're trained. So it's kind of like, okay, relax your butt. And sometimes I'll even have them put their hands under their butt to make sure it's not tightening up underneath, they can't feel it popping up under their fingers, basically. And then just see how much of a tilt you can get just using the front of your body. Bring your pubic bone in, your abdominals sucking in, see how much you can get just from that. Yep. And, then I may be working for a balance of the two over time, but oftentimes I have to wake up the abdominals because the glutes are just much louder.
Yeah. And they may have some gluteal amnesia, but when they come from physical therapy, that's a lot of what physical therapists are going to have them focus on because they have a limited amount of time. you know?
Right.
They're limited. And I really want them to focus on keeping those abs engaged because, and I've talked to so many physical therapists about this, they say you can get the core engaged in a supine position. No problem. But as soon as you get them into kneeling, standing, quadruped, any of the other positions, that's when their core just goes bleh. They can't feel it nearly as much because they don't have the proprioception and the feedback of being on their back.
Right. And that's where I find the challenge is. It's like oftentimes, to your point, with simple management techniques, sit down, flex your spine, stand with your bent knees, stand with flexed spine. Those are great. Then my second piece is always like, okay, now how are we going to create a little more strength around that core to decompress you?
Yep.
And that's where I really have to focus on, again, working in that slight posteriorly tilted position, whether it's from a Pilates perspective, footwork on the reformer with a slight posterior tilt, doing even their seated arm work with a slight posterior tilt. I'm probably not going to have them do kneeling arm work, for example, where they're really up on their knees, because the ability to keep that posteriorly tilted is pretty hard unless somebody's really, really open in the front of their hips, which they're often not. Bridging, really, and even with bridging, not going so high up into a bridge that they go into extension.
Exactly.
Right, because a bridge can take you up, and then if you go too far, you're going to end up in a lumbar extension. So really maintaining all of that in that slight flexion position while still working the abdominals.
Mm-hmm. And the thing most people don't even consider is, like you said, if they're kneeling, for instance, doing a high kneel position, if they have tight hip flexors, what's that going to do? I mean, if you listen to our last 2 episodes when we talked about the psoas, it's going to put you into extension if it's tight. So you have them kneel on their knees and be upright, and immediately with tight hip flexors, which a lot of people with low back pain are going to have, they get pulled into that extension.
Yep.
So we need to really focus on trying to stretch out their hip flexors without getting them into extension. And how do we normally do that is on one knee, 1 foot forward, but really
a lunge.
A lunge, exactly. It's sort of like
right, which is an extension exercise usually.
So we really have to be really mindful of keeping that posterior tilt in any way that we want to train for flexibility of the hip flexor. A lot of times what I'll do is a modified Thomas test and just have them sit on the edge of a table and have them bring both knees into the chest so their back is flat and just drop one leg off the edge of the table. Let gravity do the work.
And keep the low back in contact.
And keep that low back in.
Sometimes I use a supported neutral there. If they really are unstable, I give them something to make sure that low back stays in contact with something if they can't just keep it down on the table.
And oftentimes that's me. I will actually hold that other foot there.
Exactly.
And allow that
and
leg.
Make sure, and monitor the back.
Exactly. And make sure that back does not want to arch. But that is that's one way that you can keep their back flat in that position. We can also do it over a foam roller if you want, when they've understood their body a little bit more, can use the foam roller or a small ball underneath their pelvis. You can pull them in, it puts them into that posterior tilt, and then they could extend the leg out or down. That can also work. It's a little bit more challenging. I usually don't introduce that for first 8 to 12 weeks. Just let them get comfortable doing it the other way first, off the edge of a bed or a table. But that's something to think about, is the hip flexors.
Yeah, and how do you lengthen them? One more thing I'll bring up there, again, this is from a Pilates perspective, is in more classical Pilates work, a lot of it is done with that posterior tilt. So footwork is done with that way, knee stretch is done that way. So there's a lot of exercises that are done with that posterior tilt. And in contemporary versions of Pilates, we don't focus on that as much. But if I'm working with somebody with stenosis, I go right back to the classical work, and I'll have them, in that posterior tilt when they're doing their footwork, when they're doing their knee stretch and things like that. And something that I'll often do, now I can have them actively try to maintain that posterior tilt by using their abdominals / glutes, depending on what balance I want between those two. But I'll also sometimes give them a passive prop to help to push them into that position.
Yes.
And typically I'll just like a towel underneath, not their low back, but the bottom of their sacrum.
Yep.
So it just kind of tilts them backwards. Or for a long time, I had this, one of our clients was a seamstress, and she would make us these little mini wedges.
Oh, nice.
Which were maybe 2 inches high, not super stiff foam, but moderately stiff foam, and should we cover them with fabric, and that would use that as a little tiny tilt to again wedge them up. So the tailbone came up and the low back came down, because sometimes clients can't keep track of everything at the same time. You're having them do an exercise and they're remembering their legs or forgetting their back, and also sometimes clients needed that extra awareness of there.
Absolutely. I use a Togu ball or a light Pilates ball even under their sacrum. I find that a lot of especially men have a hard time understanding the pelvic tilt. They're really bound up in that low back. That thoracolumbar fascia is so tight. And I'll put a ball, mostly deflated Togu ball or 9-inch Pilates ball, or if I can find a 12-inch Pilates ball, even better, and put that under the sacrum. It almost pushes their back flat. And it's a way to get them to feel, it gives them some buoyancy underneath their pelvis. And if you have a Dyna disc, I've used those in the past too, where you just have that buoyancy and can go back and forth. And I say, don't go into extension, just go into the flexion, try and flatten your back. And then we can do all the exercises, marching, toe taps, all of those sorts of things. But it'll get those abdominals engaged in a different way because of that buoyancy.
Right, and that dynamic, right? So they can feel it. And it's about proprioception. So they can feel like, oh, the weight is shifting towards my low back and off of my sacrum, and they can feel that change. So again, anything you can do to help that. And then we're talking about it supine, but then you've got to train it in seated. You've got to train it in standing. You've got to train it in every other.
They're going to feel much more comfortable seated than standing. Now, again, I'm talking right now primarily about the central stenosis, because I've actually got a fix for the lateral stenosis that I'll go into in a bit. But for the central stenosis, if I have a choice with the exercises, I'm probably going to have them do it seated.
Yes, exactly. Me too.
Just because they're going to be more comfortable.
Yep, I'll build them up to standing or other kind, or even kneeling. I never do, but I'll build them up to standing or other positions. But I always start with them seated. So in their arm work, they're going to be seated typically on a box, so they can actually just gently slump back. And it's just it goes against all of our stand up tall, stand up straight. All of that has to be neglected, ignored. For clients to really get that idea to, yes, I've got to let that round a little bit.
And again, a lot of it is also cueing. I find even by sitting, they want to sit up straight because someone's watching them automatically. We want good posture. And I'll just remind them, I want your abs engaged a little bit more. Tuck your tailbone under, even seated. And they'll do that. They go, oh, okay. Even though they look like they're sitting straight up, they're sort of rocking back just slightly onto their tailbone.
Just a titch.
And then I can load them into a row or a pull down or even a press or any of these type of things. This may be the client that if I'm in a big gym environment, they would be better on a machine to initially get them a little bit stronger in the rest of their extremities, because they'll be in a seated position. And I can really watch their spine as they're doing the exercise and make sure that they're not arching.
This is not a free form situation. Right, like just doing free weights in the gym. It's not something I start with. I'm just going to start with things where they really are controlled, they're contained, they've got the proprioception of where their back is, and then we gradually build them up. One thing you said was ringing a bell for me. So the other thing too there is really being aware of where they're sitting. So the other cue that I use is the sit bone cue. Right, because if they're sitting. If they can most people can feel their sit bones if they pay attention. And if they're sitting up on their sit bones, they're generally neutral towards extension. So a lot of times I'll use the cue of, okay, just find your sit bones, like sit on top, now just roll back. You can still feel your sit bones, but you're on the back of your sit bones. And just that will often engage the abdominals and get them in a little bit more of that flexion, that slight posterior tilt. Because I don't want them just collapsing, because that's the other thing. I don't want them just slumping back with no support, because that's not going to get me the axial elongation, the decompression that I want. So find that sit bone and just come back just a hair. And generally to do that, the abdominals engage. Now that's where I want you to maintain while we're doing our arm work or we're doing whatever else we're doing.
What you said, I love the one word that you said, aware. That's really what we're focusing on, is their body awareness. First and foremost, before I load them, before I give them any decent amount of weight, I might give them something very light and it frustrates them. But I need them to be aware of where their body is in space. so that if they are standing, they're still doing a posterior tilt. If they're, lying down, if they're seated, if wherever they are, that they are aware of that, but also I've had a number of clients who have come to me who have already discovered this flat back technique, in that the only time it feels good is if they're in an elevator, they lean against the wall and they flatten their back.
Exactly. Or I've got a client who their relief is basically to go up to any wall they can find, or a lamppost if they're out, and just put their feet in front of them a bit, lean back into it, and just really kind of push their back into that surface.
Yep.
And they'll do that for a bit, and that'll relieve the symptoms, and then they'll carry on with their walk or whatever else they're doing.
Exactly. But teaching them that awareness of just where your body is in space. Most of our clients are completely body dyslexic, body unaware. They don't know where their body is. And just to teach them where it is in a seated position. So it's like, okay, I'll put them on a ball and put them in that posterior tilt. I'll say, just sit there. Now just lift one arm, lift the other arm. But am I watching the arm? No, I'm watching their spine. Are they arching, trying to arch? And I'll say, put your brain in your spine. I want you focusing on this. Everything else is secondary, tertiary. I don't care about that. We can load you later. I need to make sure that you know where you are in space and how to keep your back safe in space before we ever give you a decent load.
Yep.
No matter what the resistance is, whether it's spring loaded or band loaded or, weights.
I think the other thing too, to get back to that awareness, and I loved how you're just talking about how you progress and think about that. But one thing that I like to add to that is what we're really doing is empowering them, because if they can find ways that hurt less, then and this doesn't seem obvious, but I find with many clients, they need to be encouraged to make the right choices.
Yes.
Right? I mean, you would think that they would prefer to be out of pain, so they would continually make the choice to be out of pain. Many clients do not. And I really got to encourage them. It's like you have the tools now to be more comfortable. Use them.
Yes.
Right? If you're sitting in a meeting, or you're at a party, or you're walking around doing something, and you know that if you just take 2 minutes and stretch your back out, that you'll be in less pain, do it.
Yep.
Right. And that's something I find I really have to really encourage clients to really take that on as a practice, not to put up with it, not to get stoic. That isn't going to do you any good over time. You've got to just take care of it. Just do whatever you need to do to feel a little better. Oh, a little relief. Great.
Yep.
Go.
And it's also, I find a lot of people are like, well, they don't want to stand out. They don't want someone looking at them.
Right.
They don't want to look weird.
They're embarrassed.
You know what?
Yeah.
I can tell you, I just got back from Korea. I was in the airport. My back was a little bit, just nagging because of all the travel and everything. I was on the floor. I had my little release ball with me, and and people were looking at me. I couldn't give a darn. I just want
exactly.
It's like, you know what? I'm going to release this, and then I got on the plane, and I felt so much better.
Yes.
So again, who cares if someone's looking at you? Chances are nobody is. But even if they do, who cares? Take care of you first.
Exactly. And that's so important, especially honestly for a lot of my older clients, where this is typically an issue, is a lot of them have very strong feelings about what's appropriate in public, and that kind of thing. And a lot of them are just stoic. I mean, again, you said many men are more commonly suffering from stenosis, and a lot of them really do have a just tough it up kind of situation in terms of their mentality. And I've just got to say, you don't have to do that. And you will feel better more of the time if you just take these small steps. So that's another thing to really think about.
Now, something I want to bring up, because we're talking about our older clients. Okay. One thing that most people don't think about, shoes.
Okay? Oh, right. Yes.
Because how many times have you heard your client who's between 55 to 75 come in and their back is really bothering them? Well, this weekend I went to a party and they wore heels. And they don't wear heels on a regular basis.
Right.
But they have to for I'm going out.
Yes. It's their culture. It's what they do.
It's their uniform. They have to do it.
Yes.
And I always tell people, whatever choices you make are your choices, but there's going to be some considerations that are going to happen, and you may have to pay the consequences for those choices on the back end. And if wearing a 2-inch
Yep.
heel, you know, is that important to you? Hey, go for it. Just know you may be paying for it for the next 2 weeks, because being in an elevated position, every woman knows this, is going to put your back into extension.
Well, the other thing too is, okay, so if you're used to standing at the party, but you know, right, you know you're doing that, then sit at that party.
Yes.
Right? Bend your knees, sit more, like get in a position where your back's in a better place. And, you know, just say, oh, do you mind if I sit down a minute and sit down with somebody instead of standing up? So manage. Again, it's that taking empowerment, like being empowered to make the changes you need to make to take care of yourself.
Yep.
And if you've got to wear the 2-inch heels to show up and to, you know, do your thing, that's great. But, you know, spend more time sitting.
Yep, absolutely. Now, let's talk a little bit about lateral stenosis.
Yep.
Because mine is only on my right side, I've kind of really been studying this for a while, and I've had a number of clients who it's, you know, one-sided. I think on probably 8 out of 10, it's the right side. Don't ask me why. It could be just because we're right-handed, we favor one side more, who knows? But I see that it's mostly that side. When doing exercise, especially in the standing position, what I'll have them do is take that right foot forward in front of the back foot.
So you're putting a slight amount of a posterior tilt on that side of the pelvis.
Exactly. So instead of having them stand,
a little bit of a pelvic rest there.
Yeah. Instead of having them stand with their feet together, just put it slightly forward. You know, and
like half a foot length. Like, I mean, one
depending
foot
on
like,
the person.
Okay, but just a little bit forward.
Yep. For some people, I'll have it be an entire foot length. For some people, I'll put it half.
Okay.
And still remain somewhat balanced. And sometimes what I'll say is go ahead and load that right side a little bit more than the left, even if, you know, whatever feels comfortable, whether they're doing curls or they're doing lateral raises or they're doing whatever, even cable work, whatever I have them doing. Having that 1 foot forward seems to put them in just enough of a posterior tilt compared to the other side that it just opens that area up just a little bit,
Nice.
So
that's a golden gem there, Brian.
Yeah, and like I say, it works for about 80% of the clients. Now, some people it's just so impinged you're not going to get any relief from that. But that is when I will also have them focus on some more mobility stuff to really try and stretch that side out so that the QL isn't clamping down, so that their glute med isn't clamping down. That whole lateral line can begin to get grouchy. So, you know, doing some side bending, really relieving that pressure on that one side and opening up the facet joints in a lateral way as well as in a flexed way can take pressure off of that as well.
Which brings us to the topic of rotation and lateral flexion with stenosis, which I realize we've really just been talking purely sagittal with flexion and extension. So, you know, one thing that I have worked on with some of my clients is lateral flexion towards the side that's impinged, not always such a good idea.
Nope.
Right. So if, for example, if I'm trying to get length in the spine with somebody like that who's got one-sided stenosis, rather than doing lateral flexion in the other direction to stretch that out, that's where I might say, like, you know, go to in Pilates studios, we often have the trap table or whatever. Like, go take the trap table and just bend your knees until you can hang and get that elongation.
Yep.
Or one other version on the trap table is with the hands on the push-to bar, pushing the bar up overhead during supine, having somebody pull on that bar gently, right, to create a little bit of traction, basically.
Yep.
But bilaterally.
Yep.
To get the length without the side bend.
Yep.
Otherwise, if it's one-sided, I'll have them, again, just stretch that side.
Exactly.
So they'll just do one-sided lateral flexion.
Yep. And the hanging, one-sided hanging really does help because you're not compressing the other side. You're just lengthening the one.
Yes.
So I find in every gym, there's different heights of machines or the trap table or whatever. So whatever height man or woman I have, I can usually find something that they can reach up and hold on to and just gently let that side sort of shift outward to open up without collapsing the other side.
Yep. And one of the things I find with that is I've then got what I always suggest after any kind of traction, any kind of lengthening, passive lengthening exercise like that, is you have to return slowly.
Yes.
Right? Because what I have found when I'm not careful with that, or the client kind of like hangs and then they jump right off, is things almost counteract that, right? They're almost like, oh my gosh, you just overstretched me. Now I'm going to really clamp down on that side.
Yep.
So it's like, okay, now release that slowly, very gently, bring your arm down.
Yep.
Make sure you're maintaining that support of the core and that abdominal engagement as you do that. And then I'm successful. Yeah.
Yeah. And in rotation, I find that we want to enhance thoracic rotation without angering that area. So if it's at all acute, and they're having some issues back there, I avoid rotation, maybe some gentle rotation if they're doing some rowing activity or something, one arm rows, a little bit of shoulder movement is fine. But something like telescope arms lying on their side or book openers, whatever you wanted to say, I find that opening up to the same side is going to stretch it. Opening to the opposite side will tighten that area.
Yeah.
So if my side is my right side, if I'm lying on my right side and doing a telescope arm, taking my left arm and opening it up, that side's going to be a little grouchier and it's going to talk to me. And so I'll always ask a client, if I know that it's on one side for them, how does it feel today? And normally they're fine and they say, oh no, it feels good, because and in a telescope arms, I will make sure I have both knees pulled into my chest as far as they'll go.
Okay. Yeah. So they're rounded.
So they're rounded.
They're flexed in that position. Yeah.
And that can help. But sometimes they'll say, I feel it a little bit. Then we're not doing it today.
Yeah.
Rotation is out. If it's at all acute, you know what? It's not worth it. This exercise isn't going to make or break we have other choices we can make.
Yeah.
So be cautious with rotation, especially to the opposite side if it's lateral. And if it's bilateral or central stenosis, just be cautious. If it seems to bother them, take it smaller. Really limit it to just the shoulders. Really maintain that, that flexion and that spinal stability so that they're not moving it even those little, few degrees that the lumbar spine want to rotate.
Nice.
Nice. Now let's talk a little bit about cervical. We talked a lot about lumbar. Cervical stenosis can be, that's a bugger. That can be an issue.
Yeah, I mean, I've talked about this a lot in various other situations, but the challenge for me with the neck generally is it is the slave of our head.
Yes.
Right? Where our eyes go, where our attention goes, what happens when we talk, what happens when all of that, our visual field, all of that is, we don't move the neck to move the neck. We move the neck to adjust the position of the head.
Yes.
And so I find making neck position conscious is hard.
Yep.
For having clients be aware of where their neck is and how they're supposed to hold it. They can do it for just a few minutes at a time, and then they go back to automatic.
Yep.
And that's the low back. People seem to be able to find that and hold that more consistently through a period of time. The neck, it's like, it just takes forever, I find, for them to really understand where they need to hold their head and then to commit to it.
Well, the difference, in my opinion, between the cervical versus the lumbar seems to work as a unit, whereas the cervical, we can have extension of one area and flexion of another.
Yes.
So if a client comes in who's really, their head is so far forward that it's in their lap, when they're looking at their phone or something, yes, they're in forward flexion. But as soon as they look up, they may go into extension of the upper cervical while they're in flexion of the lower cervical. So that may actually be detrimental depending on where they have the issue. And that's where we see, at least I find, is it's that forward head carriage. When their eyes are up, that's when they're going to sort of start feeling it. So I need to get them into retraction to open up that upper cervical without, having their head just drop into their lap.
Right. Yep. Which is, this is typical what we do with many postural issues in the cervical spine, right? Yep. Is trying to get that retraction, getting those deep neck flexors active as opposed to superficial ones, and lengthening out that upper extended part, right? The first 3 or 4 vertebrae that tend to end up in extension when there's a forward head.
Yep.
And the other thing too there is then really working on strengthening that, because oftentimes I find the cervical spine is just not very strong. No. The muscles are not really doing their support job.
Yep.
And especially if somebody's been in pain in their neck for a long time, then really they really are not generally very strong in their neck. So then
Yep.
working on some strength with that, but again, strength that doesn't cause irritation.
Yep.
Trying to get that three-dimensional support around the neck, front with that retraction, and then even sides and back with just all the different neck muscles.
Yep, absolutely. What I usually will start someone with is just their head on either like a pillow, a Togu ball, a Pilates ball, mostly deflated, and just or even a foam roller. Put them on a smaller foam roller under the base of their skull, and just have them do what I call face nods, where they're literally just tucking their chin as they're extending. And again, the cue is the important part, extending the back of your neck. You want to feel it, go away from your shoulders as you tuck your chin.
Get longer.
Get longer. Because some people, when they hear, if you say get taller, what do they lead with? Their eyeballs. Their eyes go up.
Right.
And they'll look up a little bit.
That's right. Right. That's right. It's the front of the body that gets taller, right?
Exactly.
Yes, I'm getting taller. My eyebrows are going up. My eyes are going up. It's not the back of the head. That doesn't feel like you're getting taller. Yeah, good point.
Yeah, so these are just small things that you want to remember for cueing. And I'll do it in the supine position just because they're unloaded. And they can start to begin to feel, again, that word awareness. Become aware of where the head is in space and holding that position. And then I can even have them do gentle isometrics by using their hand, side to side or whatnot while holding that, before I'll take them into a seated or standing position where I'll make sure they're in good position, and we can do isometric. We can do, a little bit of more movement activity as well. But man, we're talking about half a pound of pressure. We're not talking about much more than that. We're talking grams, not pounds, really.
Right. So two things. One is for those guys, when I'm doing this with a roller, I want a 3-inch roller, not a 6-inch roller.
Yes.
I don't know what that is in terms of centimeters, but that really just kind of fills in the base of the neck and gives you the room. The 6-inch rollers is, I think, too much pressure generally in one direction or another.
Yep.
The other thing too is one other way that I've used for years is just I call it the 8-way head strengthener. And you can use 1 finger, 2 fingers, or 3 fingers. You put one in the middle of your forehead, and you just do a little isometric forward, a little isometric back, a little isometric to the side, putting your finger over one ear, finger over the other ear. And now you can do the corners of the head. So that's going to get, ideally, a little bit of 3-dimensional activation of the support muscles around the neck. And that's very tiny. Those are tiny amounts of resistance with 1 finger. As people get stronger, I'll then do 2 or 3 fingers, and that gives you a little bit more resistance and a little stronger activation. They're just isometrics. So again, just a little bit of that. And sometimes that'll just make somebody feel like they've got that length and that support 3-dimensionally around the neck. Starting with the supine work that you do, and I also do with the ball, and kind of get the awareness going, then taking them upright with that very, very gentle fingertip action.
Now, something for our Pilates and our fitness people, if you're doing any unilateral work and you have someone with cervical stenosis, I say let the head follow the shoulders. So if I'm doing a rowing activity, whether it be on the reformer or a cable or a band or anything, as I pull that, when that shoulder wants to rotate, if I'm using my right arm and I'm pulling back, it'll get to a point where my shoulders will want to turn to the right. I say let the head go with it so we can keep that neutral position instead of keeping my head forward and everything else turning, which is the same as turning my head to the left.
Exactly. Oh, God, that's great. So keep the head with the torso, basically, because then you're going to minimize that rotational stress on there.
Yes.
Yeah, really nice. I like that. That's a great way to think about that, because we often do it 2 different ways, right? Looking forward and keeping that forward and then adding the torso, or moving it with it. I like that. That's a great tip. Another golden tip there, Brian.
Like I say, hopefully these will help people as they're working with these clients. But I think a lot of it does come down to that awareness, because bringing them up into a seated position or standing position, if we're working the neck, or even with the lumbar spine, it's just getting them aware of what position is going to cause them less pain.
Yes.
And getting them to not only identify that, but to accept it. That, hey, yes, if it's the lumbar, you may have a little bit of a posterior tilt and you're going to think like you look funny when you stand. No one's noticing, trust me. But they might be self-conscious. You know what? If it gets me out of pain, I don't care. Put me in any position. And once they accept that and start, identifying that, you'll be surprised at how fast you'll make progress, because they'll be able to almost self-correct during the exercises.
Yes, absolutely.
You know, because they'll know, oh, nope, and you'll see them, they'll pull or do something, and as I'm saying, you know, posterior tear or something, I see them go into it, I'm like, you beat me to it.
Yeah, exactly.
And they feel proud. They're like, yep, I felt it. It's like, good. And then hopefully that will lead to their daily life.
That's creating habits, right? Because all you want to do here for stenosis is create habits that are every day, all the time, as minimizing their pain. That's what you're trying to do, and that's what they're trying to do. And when those become habits, then they can manage this for a long time and potentially put off things like a surgery or progression just by management.
Yep. Well, we covered a lot of good stuff today.
We did. Excellent.
Yeah. So hopefully you guys learned something, and hopefully, you took a few of the cues that we, gave, and hopefully they'll help you guys with your clients, take it to that next level. And again, it's just our job to, hopefully get you to think a little bit about these topics. And when you're working with these clients, to be like, oh yeah, I remember what they said. Let's try this. And hopefully that'll inspire you to, work with these clients and keep them safe.
Yeah, absolutely. And make their lives better, because again, Brian's had really good success with them. I've had success with some of the ones that I've worked with. It's all about them and managing their own issues. And again, if they can manage and decrease their pain and put off surgery or other kinds of interventions as long as possible, that's always a positive thing.
And I'll tell you something, the best marketing you could ever do is to improve someone's quality of life, because they will never go anywhere else.
And they will tell all of their friends.
All of their friends, exactly. So good marketing tip too. So thank you guys for joining us. As I said, our socials, we're at movingcombos@gmail.com. Drop us a line, at movingcombos, Twitter, as well as Instagram. And hopefully we'll see you guys next week.